speakers, and I'm also going to invite Dr. John O., who's a local physician. Dr. O was completed medicine and residency training at Mount Sinai in New York, and then he did his fellowship training in interventional radiology with a good friend of mine and at New York Hospital, and he's the chief of interventional radiology at St. Rose Dominican Hospital and director of radiology at the San Martin campus, right? That's right. John? Yes. Good. So now we get to have the fun, which is you guys get to talk to them and pick their brains, and we got probably a half hour to do that. The internet questions, I'm going to start off with one because they're so good, but one of them I really think is going to hopefully be a springboard to your question. And this is the question. As a newly diagnosed MS patient, what should I do to find out if I have Ccsvi? That's one thing, but this is the best. And is it something I need to be concerned about in the early stages of the disease? Great question. Anybody want to take that up on the group there? So, great, you go ahead. You reached for the water, but that could have been
Well, it's trying to find out what has the patient, the patient got a diagnosis. There's a lot of things we don't know, like what's their clinical symptoms and do they have already a neurologist that are working with them and so forth. But
okay, but let's cut to the reality. The patient wants to know, should she be checked out for Ccsvi?
Absolutely.
Yeah, well, that's the question. Absolutely.
Absolutely.
Okay. Any thoughts from anyone else?
So, we're on the receiving end, right? So I see this patient walk in, and this patient says, well, I've just been diagnosed, and what do I do? So, I agree that, yes, I think there is some value in being tested out to see if you have that. The trouble with that is the only real test we have that will truly identify is really a venogram. If you're going to look for real stenosis. Everything else gives us suggestions into these windows. Not to say that that's not accurate, but let's say you go down the path of having an ultrasound, let's say you go down the path of having a MR, all those findings, considering all the data that we're learning, will lead you down that same path and saying, well, this suggests positive, this suggests positive. And so the decision tree really comes down to what are you going to do with that information as you find out that you do have Ccsvi, or there's a heightened awareness that you do have Ccsvi.
Let's say you have your EDSS of half or 1, but what really bothers you most, your symptoms are mostly dominated by extreme fatigue.
So this is, it's a great question, and this is what we deal with all the time. And my job as a physician is to take all the knowledge that we have available and educate my patients in what the best thing might be. And all the data that you guys saw today and really the thought process, that's what I tell patients. I said, look, I cannot make this decision for you. I think at the end of the day, the decision has to come from you, and you have to understand all the risks and the benefits of whether it's an ultrasound or a venogram or the intervention that you might have. And once you absorb all that, go home, talk to your family, understand this better. Please make sure you make a conscious decision with good consent and good information, and that's really what it comes down to.
I think that's the right answer, and absolutely spot on as far as I'm concerned.
I have a question about that. So if you have a low level of suspicion and the patient's extremely motivated to go further for like an invasive venogram, how do you handle that kind of patient?
So that happens all the time, and from the evidence that I know in looking at MR imaging from diagnosing stenosis, I know that it can overcall or undercall. In looking at ultrasound, we follow Zamboni's same criteria, but we've modified some of the things also because we didn't necessarily find a success rate of 80–90%. And I think ultrasound in my group's hands, and we have, there's 17 vascular surgeons. It's a very large practice. We do thousands of ultrasounds every year. But when it comes to veins, I think our yield is about 60–70% at best of being a positive, of being an accurate yield. So in all the patients that I treat, that we showed you, and all the patients that I have treated, I would say, about 60% of them were positive on ultrasound, and almost 98% of them are positive on venogram. So once you go down this path, I always have this fallback and saying, I can't make that decision for you. Whether you have limited symptoms or a lot, I don't know when that curve is when somebody falls off. So I can't speculate, and that's the fun part as us doctors being at this early point, because we love that, but that's also the scary part because we don't know certain things.
Yeah, and the audience should know that ultrasound provides some information, MS provides other information, but they're not exactly the same information. And so I think they're complementary, and it's clearly, I think we've gotten to the idea that in our heads that we also need something simply besides anatomic abnormalities to really know what the real flavor of that problem is. In other words, we need physiology, we need to know flow. So as David showed you, not only imaging, but the flow rates are important. They add, and the more rich you can have with your data of imaging and physiology, the more confident you can be about deciding whether you want to go in to have a venogram and then if you want to get treated. But obviously the MR can't see the valve very well, and it's certainly not going to see intraluminal abnormalities in the valve, which are fairly common in things that are detected and can be detected by ultrasound. On the other hand, ultrasound can't see the global picture and all the collaterals and everything that you get with, you saw those beautiful images that David showed. So,
Mike,
John.
this is more an observation than an answer to that question, and it's this, it's that, you know, it's sometimes, right now, it's the neurologist or primary care physician, or actually it's the primary care physician who's going to be the gatekeeper of who you see next. But it doesn't always have to be that person who eventually gets to the bottom of your disease entity. It could be an interventional radiologist, for example. I could see you for some other reason and make a diagnosis. Then I would have to send you to someone if it's above my level of expertise. But here I become a referrer rather than your primary person. However, I can add value to your healing process by giving you certain answers that your primary care physician can never do. For example, I work with MRV. I feel like at some point in time, the functional MRA or MRV will be the key to this, to opening up the secret to exactly what's going on. Right now, for example, at the Centennium Medical Imaging, we're doing the pre and post MRVs on patients that we see for the angioplasty. So we get a look at what happens right before we do the angioplasty and right after we do the angioplasty. I think that's going to be just valuable information going forward. And eventually, I think this can be extrapolated to all parts of the country.
People are looking at all sorts of things. Obviously, the Hubbard Foundation, which many of you have heard of, actually doing functional imaging pre and post. Very interesting. And the seams are going to slowly get pulled together. Each day there's more information, and that's what's exciting about it. We're all embarked on this unknown path together, and it's kind of fun. Any questions? Yes, back.
I'm a vascular surgeon. I see a lot of MS patients in my venous clinic. Are there other venous abnormalities? Have y'all noticed anything that is an inherent problem in the venous system, or is isolated only?
So you're not seeing them for MS, you're just seeing them for venous.
I'm seeing for venous insufficiency or wound problems. Or
their legs, yeah.
Right, exactly. So I'm curious, has there been any data to look at that? And the second question I have is, onset of disease and treatment make a difference in the outcome, because you would expect it to improve if this is one of the etiologies of what's going on. Do you have any data on that? Do you understand that part of the question? In other words, if you treat them sooner in the process, does it ameliorate the disease better? Or?
So
Go ahead.
to answer the second question first, in my understanding of the evidence that exists towards Ccsvi today, and in trying to piece this together, we don't have an answer to that at all. As a matter of fact, you know, as much as I would like to study this and evaluate patients, I'm always guarded when that patient, so Mike's first question was the patient who comes in who has limited disability. What does that patient do, he or she? Do they just say, look, I gotta get treated because I'm gonna get better? The reality is, you know, the pendulum is moving in a direction that's giving us evidence that over short term people get better and it's relatively safe a procedure, but we don't know what the long-term implications of this would be, and that's why it requires this effort of being safe but forward-thinking in making progress.
Yeah. We don't have a long-term follow-up. We know people symptomatically, a number of people get better, but we don't know in terms of lesion load, if that stabilizes, if it somehow alters the trajectory of the disease process that is characteristic for that patient. It's just not that period. But certainly, If you have a low EDSS and you're motivated, you understand the procedure and the rest, and your symptom complex is dominated by these global constitutional general things such as fatigue, heat intolerance, nocturnal enuresis, brain fog, that sort of cognition issues, if you're treated, you can have a real response in those to the point where you can almost be asymptomatic. If you're farther in the progress, where many of your symptoms are more sort of on neurolocalizing, like maybe a single hand or a foot or something, which may be due to a demyelinating plaque that happened to hit a particular area in the brain, certainly in the short term, those patients, when they're treated, are not going to magically remyelinate overnight that demyelinated plaque. They may have some benefit from that in terms of whatever those symptoms are. We don't understand that fully, but I think in general, at least in my experience, the most profound responses have been in this sort of global general area, which to me makes me think that some of these symptoms may be more accurately or more, I think, better characterized as being due to venous insufficiency rather than the actual MS plaques.
We were surprised to find this, but over 80% of the patients responded positively.
Yes.
I have two questions. The first one is for anybody in the panel. What is the link between venous insufficiency, iron deposition, and the immune system? Why would the immune modulators also show benefit in treatment of this illness or stopping progression? And the second was more of a technical question for Dr. Mehra. What is your approach for doing the venogram in bilaterally, obviously? So those are my two questions.
Okay, first question was about how really the venous insufficiency, iron, etc., really factors into this, and why don't, in the immune system as well, and why don't.
So the short answer is we really don't know. It's speculative. But what we do know, as more and more evidence is coming out, is that if you buy into what Ray had shown earlier, that maybe it is this component of insufficiency, reflux, and other things, what Zamboni has shown and others have reproduced the data, that if you improve flow dynamics through the jugular venous system or through the azygous vein, it is very possible that you might have a pressure issue, a flow issue that clears things better, and or certainly prohibits or prevents some of that diathesis where the red blood cells who are stagnant against walls of tight junctions in the blood-brain barrier and stuff could have an impact. Now this is theory. We don't know if this is a fact, and I think time will tell what that turns out.
This is a long lecture is what it is. And again, in the end, it's still kind of hand-waving, okay? And so you got to realize that. But there are many ways you can. I personally think it's the sustained. These pressures that we're talking about pressure are not pressures like pseudotumor or benign intracranial hypertension. They're not big-time pressure gradients, but it's low, sustained, chronic pressures. Now, here's a question from the internet. Why does MS onset late in life occur if Ccsbi is caused by congenital malformations? Great question. No answer. We don't have that yet. It's one of those things, but I think and we could add about 100 questions to that. It's sort of you get on the string and you just got to follow the string. You got to keep seeing where it leads and working through these things. We got all sorts of questions now, which is great. I think I have to be fair. The first person I saw was in the back. Yeah.
I have mitral valve collapse. Is that anything to do with it?
You had what?
I have
Mitral valve prolapse. Well, I have mitral valve prolapse. I'm not sure. Well, obviously, there's so much we don't know. We don't know that relationship. We could talk about renal veins. We could talk about iliac veins. Some physicians always look at the iliac veins before they go to the jugular. Some people are treating renal veins. We don't know. That's the bottom answer. So I can't really tell you. Thanks. Sorry about that. But yes, right here. Oh. Yeah.
My partner, he's got severe spinal stenosis.
Well, there are a number of other disease entities that you think we don't have answers to the MS. There are a lot of fast followers to MS. I've been treating people with POTS. You ever heard of POTS? Postural orthostatic tachycardia syndrome. A high percentage of those have Ehlers-Danlos type 2. When we look at them with ultrasound, lo and behold, they've got positive Zamboni criteria on ultrasound. Amazing stuff. And Ray has a patient, right?
Yeah,
Yeah, I just treated a week ago, feels miraculously better. I don't, there's that. And we've got things like Parkinson's, we got spinal stenosis, we've got even chronic fatigues, and all these things are being looked at. And obviously, just put yourself, if you're a neurologist, you would find this whole thing just overwhelming, almost a tsunami of people attacking you with new diseases every day that they think are due to veins. I think it's very easy to just say, no. Yes, how about,
My
right,
question,
and then you'll be next. Okay,
I'm
so.
coming from the chronic fatigue syndrome community. I have neurally mediated hypertension, probably low blood volume, which would make those veins stenose. So my question is, are you looking at low blood volume, not low blood pressure, to see if maybe that might be the backup that's
Well, there are a lot of sympathetic things that play into this dysregulation. As you well know, about 50% of people with MS have low blood pressure. Not low, so they're fainting, but on the low side. I have many patients when they come in, after they get treated, I'll get emails saying, I haven't been able to wear my wedding ring in blankety blank years because it always fell off. Now it stays on my finger. And now nurses can draw blood out of my veins, which were always hard to do before. Well, this is obviously, there's something, this isn't me treating this up here that all of a sudden they end up with. This is a sympathetic effect in a very complicated neuroregulatory system like the brain that we don't understand.
The person is constantly dehydrated where there's not enough blood in their body, almost as if they've been in a terrible accident.
I don't know. Anyone?
Actually, that's an interesting point. If they have low blood pressure and they have stenotic veins, their pulse pressure is going to be lower across their entire cerebral vascular system. And we know from how patients respond when you offload them for doing endovascular, T-bars and things, how it can improve if you increase the pulse pressure. So that's actually a good theory of what may be going on.
Yeah.
Well, there are a lot of theories. We'll have to see if we can prove some of them. Yes, second row. Yeah.
Okay, first one is just kind of a statement in regards to the statement about neurologists. They're very negative. They will not refer you to anybody. In fact, they will, and you'll have to be a MS patient for them to say they will drop you if you're going to go through the procedure. Second is basically a question for everybody on the panel about a person not diagnosed with MS, but having a positive MRV, left jugular collapse, and both valves, not inoperative, but partially inoperative.
Well, that second question is going to be hard to deal with, except to say that we all know that there are a lot of factors, multifactorial disease, and each person has their own mosaic that puts together which pieces fit together in what way and how the positive venogram, MR venogram you're talking about fits into some mosaic. There may not be any of the other pieces that fit in there because unlock the MS combination there. We don't know. There are more unknowns than knowns, obviously. But when you're dealing with something as complex as this, and as multifactorial as this, you're looking for things that you could potentially reverse. Now, that doesn't deal with the patient who doesn't have MS, but for those of you who do have MS, you're constantly thinking how, and I think, I guess Ray said it best, what you want is to take control of your disease as best you can and look at each one of these things critically and say, is this for me? Whether it's vitamins, whether it's diet, whether it's this, whether it's that, whether it's Ccsvi, how do I get that and decide for me and take control of it? And you will make resistance, certainly, at many times, and you just have to power through and do what's right for you.
Also, a stenotic vein may not necessarily be MS, or the diagnosis may not have actually been made yet. Or it could be another neurologic phenomenon that is not MS, but still can be treated by angioplasty and the symptoms resolve.
Front row.
Asking for my friend Tony. Tony's fairly severe in symptoms. I don't know that much about MS, but it seems to me he's fairly severe in MS. And I want to know, kind of quick two-part, guys, sorry. But if his symptoms are like walking 25 feet, for instance, I know he has difficulty walking at all, and maybe with a walker. So if he's that symptomatic, or is there health, or is it like more health because he is that symptomatic? And the second part, real quick, what's the best way to get him on a trial, some sort of a trial or something? So.
Okay, well, anyone can take that. I would just say that from the literature, we do have a starting to emerge a sort of a characterization of the patient who's most likely to respond. And we could talk about that. It's usually patients who are younger, happens to be women more than men, it's patients who are relapsing, remitting, it's patients who have, and this is emerging out. But in terms of a trial, I'm very much in favor of looking locally and getting treated locally. One of the problems now, of course, has been sort of referred to sort of in a derogatory sense as medical tourism. But that's all that was available, patient, and so we see this snapshot in time and everyone gets very upset, but that will change. It just takes time, and this is playing out, unfortunately, almost like reality television, it's so in your face that we kind of think that it's not moving that fast, but it's moving very fast. But the ability to get treated locally should not be discounted. If you have someone who has experience, and you should look for that, then you have the opportunity to get follow-up, to get everything. And it sounds like in Las Vegas there's emerging opportunities, so that's what you should look for first.
And the improvements don't have to be that you can all of a sudden run a marathon. What I've noted, and I've treated patients with primary progressive and secondary progressive, and the improvements sometimes are so subtle, but they're enough that they change the quality of life significantly for the patients as well as the surrounding people that help them on a day-to-day basis. And it's one of those things. It's not that we're all up here trying to advocate that you have to go have this done, but I think there certainly is evidence that's telling us that there is something here that improves flow in certain ways, and that's where the whole flow phenomena that Mike was talking about becomes really important. It's not just about a narrowing, it's about what is that blood doing across those veins.
I think most of us up here truly in our hearts believe there's a signal here, that we got on this string, we're following the string. And for each patient it's going to be different. No one has ever said this is a cure for MS. It's not a cure for MS. What we're looking for is better quality of life, and that hopefully that this is tied to some physiological improvement that we can measure, and then get the legitimacy out there so people will help us get better treatments. Because quite frankly, the treatments we have, angioplasty plus minus stent, may not be the treatments in 3 or 4 years from now. These are not treatments that have a tremendous success elsewhere in other venous beds throughout the body. It's what we have now. It may not be the best directed at the problems in the veins we have now.
I think that's a great point, what you just said, is because think about the legs and the varicosities in the legs as an analogy to the brain. You can't really see what's going on in the brain, but you can see what's going on in the legs. And what you see in the legs is you see iron deposition, like you were saying, because the red blood cells have hemoglobin, have iron, hemoglobin, and it eventually gets onto the skin when there's blood pooling and can't get back to the heart due to insufficiency. But when we treat the veins in the central venous system, we're using angioplasty. So I think that's an excellent point. And 5 years down the road, we may be doing something else in order to combat this disease.
How about 2 more questions, and then we'll probably stop the formal, but some of us may hang around, some of us have to go to somewhere. And so, yes, front.
My question is about the safety of the procedure. Can you quantify the radiation level during angioplasty? And the second one is, how safe is the contrast that you use in these venograms?
Those are both good questions. Number 1, radiation exposure. Number 2, safety of the contrast media that's used for the venography. Who wants to take that?
I'm already.
John, you're the radiologist.
I'm a radiologist. So, yeah. This is what we think about radiation. We try to give the least amount of radiation possible in order to gain a benefit.
Can you quantify in rems or millisieverts?
Yeah. Geez, you put me on the spot as far as millisieverts. That's our but it's it's less, the amount of radiation that you would get is less than having a CT scan of your chest. So it's less than that. The amount of radiation you get for a CT scan of your chest is about 1/100th of just one view chest X-ray. So the amount of radiation, if you take it all comers, is going to be insignificant for any adverse biological effects that you have going forward, unless you're getting a CT scan every other day. Because your body has a chance to heal itself of any biological effects of radiation over a period of time. It's only when you get inundated with radiation where you're at a higher risk for...
I would just say two things about radiation. We don't have a good, what we would all like is what you would like is you would have a card in your wallet that would have your lifetime radiation dose, and every time you had a procedure, you just keep adding it up so you know where you are. In point of fact, we can't do that because so much of your radiation when you're doing an angio is not like a CT scan. CT, we can do that. They're pretty, but when you're on an angio table, the II, that image is always moving. That changes everything. We have to deal with things like dose area products, and it gets very complicated to get a radiation dose. Certainly in young people, we're extremely sensitive to that. What we're worried about is the cancer of certain things that are radiosensitive, be it thyroid, being it. But when you get to be my age, let's just take me, let's pick on me, the risk of me having any untoward effect is basically nil. I'm so old that I'm not going to develop cancer from any radiation, but it's not going to happen.
Sorry, who is the manufacturer of the equipment?
Pardon?
Who is the manufacturer of the equipment?
The manufacturer of the X-ray equipment, it could be anyone. It could be Siemens, it could be General Electric, it could be Philips. Why do you ask who the manufacturer is?
Well, they should know the levels. They
It's
should
not,
be able
but
to
it's not a
calculate
legal
the
tender. We
radiation
don't push a
level.
button and say, here's the exam. The exam has this. That's what that's what I was trying to say. A CT is like that. But an angio procedure where you're having multiple different views, you're moving up, you're moving down, it may take 30 minutes, it could be hard and take an hour and a half. There's no way to put a label on what that would be. In the room, it can be monitored, such as when you came out, the doctor can tell you this was your exposure. That can be done. But it's not going to be the same number for you and you and you. It's going to be all over the place, depending on certain characteristics of who's doing it, not the equipment. Now, contrast, the only times we really worry about contrast now is if you have a documented allergy to contrast, or a documented allergy to certain things like shellfish, or if your kidney function is in some way compromised beyond certain levels, and that's all checked for beforehand.
And the level of contrast you receive during the scan does not exceed 0.2 cc per kilogram of tissue. So they don't go beyond this. That's the safe level that you can receive in one dosage.
Good question.
Yes. You had spoken about patients who have had the procedure, and I believe the gentleman who was doing the imaging stated that they tested the patients prior to the procedure and then flow quantifications after the procedure. Is there any protocol that's being suggested to the large number sites that they participate in follow-up imaging to find out what the quantitative flow is? Because I know, like my wife and Terry.
I think that will happen. We're not there yet. I mean, right now, it's very difficult to find enough sites that in this country where the patients are not coming from a long distance away from. Now, I have many patients who are here who came to me, but it's a real burden on them to have to keep coming back to me.
Right.
So that follow-up and getting those flow quantifications on a recurrent basis, right now, unfortunately, it involves travel and a lot of it, and that needs to change.
Even a conventional MRI post-procedure, I know my...
Conventional MRIs post-procedure is no problem. Those translate. But when we start talking about flow quantification and certain protocols, it can be tricky. And right now, it's something that should be done, but it's not being done now because we haven't yet established what the standard is.
Well, I do have on the ms-mri.com website, there's the full protocol that we have for imaging for Ccsbi, and there's also variations. If time is limited on the magnet, there's one that's presented for a quick 2D time of flight MR venography and acquiring full slices in 3 different levels of the neck. It takes probably about 30 to 35 minutes of acquisition.
David, point out that the 2D time of flight MRV pre and post does not use any contrast.
Yes.
Yes.
So post-treatment, if you want to go in, it's almost unnecessary to receive.
In the
treatment
full Hakey
contrast.
protocol, the only reason contrast is used is to get the imaging of the hyperintense lesions and some highlighted 3D MRAV data.
Okay, great. Thanks, John. Thanks, David. We've been abandoned by the others, but that's okay. And if anyone has a question, Carol, I'll be around. Do you want to ask one of these?
Yeah, I do, because I think it's a challenging question.
Okay, challenging question. Last challenging question.
Okay, if you were a parent of a child with a severe disability who was diagnosed with MS, would you encourage a parent to have their child check for this?
I would. Let's take it. If it's my child, I have 4 kids. If it were my child, I'd certainly want to check this. You may recall that Zamboni, this is kind of interesting, it's a little anecdotal, I can't, but he personally told me this, so it's not just a one-to-one thing, but he, you know, when you're in Italy, and I spent a whole year in Italy on a sabbatical, when you have to be a professor, it's unlike anywhere else. They send you away. They send you off from your city, off to somewhere for purgatory for you don't know how long. He got sent to Sardinia. And it turns out, of all the countries in Europe, Sardinia has the highest frequency incidence of MS. And while he was there as a vascular surgery fellow, or whatever he was, young faculty, before he could come back to Italy to be a professor, he was seeing a number of little kids who would have these masses in their neck. They'd like stick out, they found out they were actually venous aneurysms. Okay? And some of them were so big that they would have to kind of go in and resect them and do things like this. And so 22 years later, when he was onto this thing that we all know as Ccsvi, they went back and they looked at all of those children. He found 20 of them. And of the 20 children that he saw, that he could find now, 20 years later, 19 of the 20 had MS.
When is he going to publish that?
Well, I don't know. Thank you all very much. I appreciate it.